I'm Palmer MacKie. I'm in the Department of Medicine at Indiana University School of Medicine, and I'm the director of the Integrative Pain Program at Eskenazi Health in Indianapolis. Well, I think we're supposed to talk a little bit about addiction, about how the current practices within the United States and Indianapolis in particular have resulted in the spread and explosion of addiction. And there are a lot of reasons that addictions begin. Within the medical practice, they frequently begin because they're given a medication which causes physical dependence and causes some benefit to the brain. And what I mean by that is that the reward system and the pleasure systems in the brain get stimulated by some of the medications that we use. And for some individuals, that little bit of stimulation leads to a lifetime of problems. So we use medications for a variety of reasons, and you can call street drugs or prescription medications. We use medications to either give us something or to take something away. And oftentimes for street drugs, we want to get something. We want to get high. We want a different feeling. Even the pursuit of something more noble, such as spiritual enlightenment. People use medications, and different cultures have throughout the time that they've identified the botanicals and fungus that create psychotropic or mind-altering effects. But in the United States lately, a lot of people have been given medications, and in particular what we've been focusing on in our work in Indianapolis and Indiana is the use of opioids. And with the use of opioids, many people are started on them to get rid of things, not to get things, to get rid of the pain. Or in the case of some sedatives like Xanax or lorazepam or Valium, to get rid of anxiety so that they can feel better. The problem with over time is that medication begins to take on a greater and greater role in their life, and the acquisition of that begins to take a greater and greater role in their day-to-day activities, so that the activities of normal living, getting up, rising, being engaged in relationships, tends to drift away as more and more time, energy, and focus is spent continuing the supply of those medicines. Why does that happen? It's not a character flaw. It's not a lapse in moral character at all. What happens is there are environmental factors and genetic factors. So some individuals are genetically predisposed towards addiction. We know that from alcohol. We know it from other types of compounds, including opioids and Xanax. And so when one gets exposed to a molecule, a medicine, or a drug, it doesn't mean that they will necessarily become addicted. It means that there's an increased likelihood. And so there's a genetic component that is you're born with it, but then there's an environmental component. If you're never exposed, if you never receive that medication or that drug, then addiction obviously would never occur. But when you do have that genetic susceptibility, that predisposition, one should be alarmed at that and operate accordingly. With the environmental, there are a lot of environmental factors that contribute into addiction. One is exposure, so exposure to a chaotic lifestyle, particularly growing up, exposure to very permissive philosophies with respect to intoxicants, whether it's alcohol, nicotine, illicit drugs, or the misuse of prescription drugs. And then peer pressure. And what do your friends do? Those people that are critical to you, how do they behave with respect to these molecules, with these chemicals, with these drugs that can take over your reward system in your brain? So another really important aspect of this is the environment in which you receive this medicine and what you get out of it. Over time, what you get out of it diminishes. And so oftentimes people don't continue taking it because they're getting high and having a wonderful time. They continue to take it so they don't feel bad, or the negative reinforcement. They're preventing bad things from happening. And so what is the environment that so many people receive these drugs lately? That environment has been a doctor's office. That environment has been under the guidance and care of a healthcare professional. So how would these bad things happen? Well, we started to use opioids, the very, very strong physical dependence medications, more and more during the early 90s and for the next 15 to 18 years. We took pain very seriously. We were advised to do this by professionals, the leaders in pain management within this country. In fact, one of the individuals who helped define how pain mechanisms work argued that the reason that we have pain problems, so many pain patients in this country, is that we're not using enough opioids, enough morphine to manage their pain effectively. And so we began doing that. And if you charted the course between when healthcare providers were instructed to use these pain medicines, when pain advocacy groups demanded better pain care, and appropriately so, and the healthcare experts said we absolutely will use more morphine, you can see an ever escalating kilogram per person elevation in opioids from the 90s up until 2013. The really devastating aspect or repercussion of this is that if you look at the mortality data, the number of people who died from overdose during that time, it mirrored that increase in opioid use almost exactly. And so we had devastating occurrences. But even more than that, for every one person who dies, there's 10 that should be entering treatment. And for everyone that should be entering treatment, we have multiple visits to the emergency department. So these well-meaning providers trying to help these patients who they care for ended up creating a culture of dependence so that they would continue to come and they would in fact report benefit. But it wasn't objective data. When we got objective data, what we found often was the pain was actually worse. Their function declined. And they experienced a series of physiologic detriments that then led them to be treated for other conditions. So what kind of physiologic things happen when you take opioids? Well, you can have problems sleeping. You can actually have an increase in your pain so that your ability to tolerate pain is diminished. And then you go in and you report, I'm having more pain, doc. And the doctors, believing that, knowing that we should use pain medicine, simply gave them more. At higher doses, the gonadal function tends to decline, so the testicles don't function the way they should in men. So you have sexual dysfunction. You can actually have an increased risk of bone disease, osteoporosis. In some studies, there's been an increase in myocardial infarction and heart attacks, in falls, disordered sleep. In fact, if you look in a study and you look at the quality of life domains in individuals who take high-strength opioids on a daily basis, and you measure the 8 domains of quality of life, pain, general health, vitality, social interactions, the ability to engage physically in your role-playing. In every one of those 8 domains, patients with chronic pain who take strong daily opioids scored lower in function than the group on intermittent opioids or the group who were never started. And one of the really interesting and almost, you would say, paradoxical responses is that if you were never started on the opioids, you were 4 times more likely to recover from your pain. And now this information has come out in some disability claims data that you're more likely to feel disabled and function as though you are disabled if you get started on opioids very early and you're recovered in their scheduled opioids. And so we're realizing at the very moment someone is injured in our efforts to try to help them recover, many times we've retarded their ability to regain their normal lives. The longer people take the opioids, the less likely they are to ever come off of them. The higher the dose that they're on, the more likely they are to kind of progress or mutate, not from being treated for a pain problem, but now needing treatment for a substance use disorder. And so a lot of this kind of started innocently with providers wanting to help and believing in their patients. But it's devolved into an iatrogenic epidemic of opioid abuse. Iatrogenic meaning it was started by the care of healthcare providers. And it's epidemic in the sense of the mortality and morbidity that has been incurred with prescription opioids and the amount of opioids that are now available on the streets. And really sadly, when one opioid gets removed, people shift to another. And lately, in Indiana, as in other parts of this country, they've shifted to heroin. And so the addiction, this iatrogenic opioid epidemic, has led to a decrease in functioning, an increase in disability, even obesity. It's associated with depression and anxiety, weaker bones, a lack of resiliency in these individuals. And then all the ones which make the press: HIV, hepatitis, and crime, and other infections that are born out of addiction. When people become desperate to continue receiving these medications, they do desperate things that they would never do otherwise, because their whole identity is wrapped up in getting that medication. They've lost what we would consider to be more appropriate saliency or driving factors. How do we receive reward and positive feedback in our life? The dopamine, which is the major reward chemical, gets taken over by these medicines. So in order just to remain kind of mediocre, middling, satisfied, they have to keep taking more opioids or alcohol or cocaine. And so some turn to performing sex acts for people. That leads them to get exposure for sexually transmitted disease or physical abuse. I mean, in Indiana, we have an inordinate level of child abuse and early childhood death. Those things don't happen. Those are surrogates. The child abuse and the unwanted child fatalities are surrogate measures of addiction and mental illness. And those two are certainly related. The mental illness tends to run with substance abuse. So we have crime, we have sexually transmitted disease, we have intravenously transmitted disease, we have a lack of functioning workforce, and cardiac problems, immune problems, endocrine problems, emotional problems. It just is remarkable what we thought is a good idea has ended up doing. So it's kind of an overview of what I feel has happened, is that we have a bunch of caring providers who listened to the national experts and the advocacy committees and took pain quite seriously and altered their paradigm and started to use opioids as frequently the exclusive modality in the treatment of pain. Over time, millions and millions of people ended up taking opioids. A statistic that's thrown around is enough for every adult to receive a bottle of pain pills in the United States. That sounds like a lot. 240 million prescriptions sounds like a lot, and it was. It became incredibly easy to find opioids on the street, and people became physically dependent and then addicted. They have substance use disorders to prescription opioids, born in retrospect out of ignorance on our part. But now we've learned. We've learned that we can't do that any longer, and we've learned many physiologic downfalls to doing that in terms of the way the body works. But much of this addiction, with the genetic predisposition and the environmental factors playing into it, have altered the way the brain works. And it is through the brain that drives our emotion, and that sense of saliency being lost and then being replaced, usurped, hijacked by the opioids, leading to devastating consequences. You could look at probably the pinnacle of the devastation, example of which would be in Scott County, Indiana, where the Opana outbreak, individuals learned how to abuse Opana by injecting it. There was an HIV outbreak that was unbelievably caught and brought under control by the health department here and help from the CDC. But now there's the cleanup. the cleanup of the emotions, the cleanup of the physiology, the cleanup of the economic vitality of that community. So we've learned a lot, and we have yet to learn a great deal more, I'm sure. And I'm hopeful that we have a new paradigm shift, a paradigm that looks more at functionality and looks more at the individual and less at the illness and the pill bottle.